Good evening, everyone, and welcome to Breast Cancer Now, to our Facebook Live, our Q&A. It's lovely to have you with us this evening. If you have any questions for our live, please do post them in the chat, and any unanswered questions we'll reply to you in writing in the next few days. Of course, if you do have any questions outside of this live, you can always contact our helpline, Ask Our Nurse service, or you can message us on Facebook. Do remember that tonight's live is a public space, so any questions that you do ask will be in the public domain. So let's get going. Without further ado, it's my pleasure to welcome my colleague Addie. Hi, Addie.
Hi there, Vic.
Hi,
Nice
thanks
to
for
see you.
joining us tonight. Yeah.
Pleasure. It's my pleasure.
So, Addie, let's crack on with our first question, shall we?
Sure. Yeah,
So,
absolutely.
we've had a couple of questions in advance, Addie, and someone's asking, should women with extremely dense breast tissue have an MRI? Now, Addie, there's not a lot of information with this question, so I don't know whether this person has had a breast cancer diagnosis, but maybe you could cover that question
Yeah.
from without a diagnosis or with a diagnosis.
Yeah. So, thanks, Vic. Yeah. So, this lady's asking about extremely dense breast tissue, which many women may be diagnosed with. Sometimes they're not told about this, but generally, what we mean by dense breasts are so the breast is made up of glandular tissue, which is hormonal tissue, which tends to be in younger women, premenopausal women. Or fibrous tissue, which is harder sort of tissue. But also fatty tissue as well, and connective tissue. So dense breasts are the amount of glandular tissue versus compared to the amount of fatty tissue. And because it tends to be younger women, some women say postmenopausally, if they've had HRT, they might have dense breasts, what they call dense breasts. And some people will mention it. Some doctors will mention it when they have a mammogram, for instance, and say, "Oh, this lady had dense breast tissue." Now, it can it can be a bit disconcerting, because if you're told you've got dense breast tissue, there's not much they can do about it. What happens is that it can mask occasionally it can mask something more sinister, like a breast cancer, because it shows up as sort of quite dark, whereas cancers usually show up as white on a mammogram. So mammogram's not always useful for showing up dense breast tissue. It can also they're still researching really about whether it actually increases the risk of breast cancer. They think the reason it can do is that the more glandular tissue you have, the more breast cells you have, so in clusters, which means that the more cells you have, the higher risk they are of turning into cancer cells. I don't know if I explained that particularly well, but
Yeah, no,
so
that's
yeah, so I mean, if you have got dense breast tissue, yes, and it depends on your age and completely, where the breast tissue is. But an MRI can be really useful, because that shows up different things. It can show up sort of softer tissue softer tissue conditions. But if you're old enough to have mammograms, for instance, I think sometimes they will there's other imaging. Ultrasound can be useful, but again, it's not always, the clarity isn't always that good. So they sometimes do ultrasound to complement the mammogram, if you've had a mammogram. So, a lot of centres are now doing what they call contrast enhanced. Oh, contrast enhanced. Disappeared.
Are you okay there,
It was
Addie?
still
So,
there.
yeah, you're talking about the contrast enhanced mammograms, is that
Yes,
right?
yes. Sorry, that
And
my
that's
my
relatively new,
screen's
isn't
just
it?
disappeared. Yeah.
Oh,
So
goodness.
Oh gosh, sorry, I'm back again. Um, yeah, so that's relatively new, and it's still really in. It's only in a few centres, so Leeds, King's College, London, um, the Royal Free, I think. So there's only certain centres that are doing it, and it's more research based still. But I think that's going to be something that is going to be used much more frequently in the future. Um, I think some people are campaigning as well that women should be told about, if they have got dense breast tissue, so that they can sort of maybe opt for additional imaging, but it's not actually a sort of a conventional. They're not conventional tools anymore at the moment. So if you are someone who's been told you've got dense breast tissue, I mean, the radiologists who report on them are the best people to speak to. And certainly, if you've had a breast cancer diagnosis, then really you should speak to a team about what other sort of forms of imaging you can have. With if you're having yearly imaging, yearly mammograms, etc. So, yeah,
And it's complicated, isn't it, Addy? Because this person that sent in the question said extremely dense breast tissue, but we
yeah,
know there's a scale, don't we? So
yes,
all of us will have a degree of dense tissue, but it's to what amount, isn't it?
exactly,
And I
yeah,
wonder, it's about looking at the whole picture, isn't it?
yeah,
How your family history, to be breast aware, and
yeah,
it is, isn't it, to talk to your team, be that your screening team,
yeah.
to really identify the situation for you. And it sounds, Addy, from what you're saying, that there's a lot of research going on, as to the best way to screen
Yeah.
everybody, isn't it?
Yeah, there is, and there is also, as well as the contrast enhanced mammography or tomography, there are different. So they're doing fast MRI. There's research on fast MRI. So just doing MRIs in a different way to check on breast density. So, there's a lot of research going on because they realize that it is actually, I think with the clarity of digital mammography now, it is much clearer, but it is showing up that there are a lot more problems occurring because of that, including
Absolutely.
dense breasts. So yes, and
Yeah,
you're right, it's
it's a
about the
really good question,
breast
isn't it,
awareness. It
Addy?
is.
Because you do hear in the press, don't you? Oh, dense breasts
Yeah.
and then lowering the screening age. So it's just a combination of things, isn't it? That isn't
Yeah.
necessarily an easy answer, but it's to look at your individual situation, which I think is really important, and be empowered to be able to talk to your mammographic team about
Yeah.
your situation. I think that's and thank
Absolutely.
you to the person that raised that question. It's
Yeah, absolutely. And I think you hit the nail on the head as well with being breast aware. I think getting to know your normal by checking regularly, whatever age you are, and particularly between mammographic screening, because people think that's a cure all for having their regular screening every 3 years. But checking because your breast tissue changes throughout the years as well, doesn't it? So, you might lose a lot of that glandular tissue, in which case the density might actually disappear over years. But
yeah.
it's about being aware of what your normal is, so that if you find anything new or different, always report it to the GP, even if you've only recently had a mammogram. So being aware is really
Yeah,
important.
that's really important. And I
Yeah,
think, Eddie, if anyone's unsure about this, then this is a really good example, isn't it, of something that people can ring us on the helpline or write a written inquiry through our Ask One Nurse
absolutely.
service, or again you can message us on Facebook, and
Yeah,
our team will be able to respond to your particular circumstances. So
yeah.
thank you to whoever wrote that question.
Yes, absolutely.
It's really good, and as you can see from Addie's reply, something that's not necessarily straightforward.
No, it's not straightforward. You're right, Vic. Um, so we've also had another question actually that I'll ask you, Vic. Um,
Mm.
it's from a lady called Tiffany, and she's saying, "Is stage 4 a death sentence anymore?" And I presume from stage 4 she means metastatic or breast cancer that's gone to another part of the body from the
Yeah.
breast.
So
Yeah,
secondary breast cancer,
secondary.
yeah.
Hmm.
So Tiffany, that's we're getting some really good questions in, aren't we, tonight?
Yeah,
Tiffany, that's a really interesting question. And of course, stage 4 means secondary breast cancer, cancer that's spread outside of the body. So that means that it can be treated, but in the words of many medical professionals, it can't be cured. But we know particularly over the last decade and the last few years, there's been so much research into treatments for secondary breast cancer
yeah,
where actually people can live well with the disease. And certainly at Breast Cancer Now, we're so focused on that, that's part of our engaging and enrolling strategy, that we want people who have a secondary breast cancer to live well with that disease.
yeah.
And sometimes, Addie, it's, there's talk of it being classed as a chronic disease, isn't it?
That's
Because
right.
people live with it for so many years.
Yeah.
And like our previous question, it does depend on everyone's situation, because we know that breast cancers are different.
Yes, definitely.
Primary breast cancers are different, secondary breast cancers are different, and the way that they spread may be different. Is it a death sentence, Tiffany? In answer to your question, it's a breast cancer that cannot be cured,
Yeah.
but you can live well with that disease.
Yeah. Yeah.
So and people do live well with it. But I would suggest to you, Tiffany, we don't know your situation. Again, if you want to
That's right.
call us on the helpline,
Absolutely.
then we can, or ask our nurse service, or whichever means that you want to, then we can talk it through, and what stage 4 secondary breast cancer actually means for you.
Yeah, absolutely. That's right. And we do provide obviously different services, don't we, for living with secondary breast cancer. We've got a lot of health information that we can offer. So if you phone the helpline, we'll be able to email you or send you that information and the services that we offer. So
Absolutely, and there's
yeah,
a lot of the services are really they're getting more and more, aren't they, for people living
yeah,
with secondary breast
yeah,
cancer? Our forum, our face-to-face groups. So yeah, I
yeah,
hope that does help you.
yeah. No, I think that's yeah. And good luck to you, Tiffany. I'm glad
Yeah, absolutely,
you've
absolutely.
asked the question. Hopefully we'll hear from her on the helpline.
I hope so. I
Yeah,
hope so,
yeah,
Tiffany.
yeah.
So we've had a question in from Emily. Emily says, I'm on letrozole and getting really bad joint pain. What can I do to help myself? I don't want to have to stop my medication. Addie, this is something that we hear a lot
Oh,
about,
we
isn't
do,
it? And I think
we
most
do.
lives that we do,
Yeah, there's
it
those
comes up in a
questions.
theme, doesn't it?
Absolutely,
Yeah.
because it's obviously something that well, we hear from maybe a minority of people that really suffer with those side effects, but for them, it's really awful, awful. And we know that letrozole, I don't know how long you've been on it, Emily, but we know that, often the side effects such as joint and muscle pains are particularly common with letrozole if you are going to have those side effects. So we know that mostly after a few months or 3 to 6 months, they usually wane if they're going to. But for some women, like we said, it can continue. So we do, I think there's a lot of people out there who resonate with what you're saying. So and I understand, we completely understand that you don't want to stop don't want to stop the treatment, don't we? But there are things you can do. So it depends on how long you've been on it. If you've given it a sort of good go for 6 or 8 months, and you're thinking, oh, you know what, this is getting worse, then obviously the obvious thing about speaking to your team, I think is really important, because there are options for you. So if you speak to your breast care nurse or treatment team, sometimes they can, you can have a break from it to see if those side effects actually are due to the letrozole. So it could be that, maybe you've got pre-existing sort of, or an existing condition of arthritic pain, and it's not the letrozole at all. So it's just about maybe taking a break from that. Um, but in discussion, with the team. You might, because some people think that changing the brand might help, and we do hear that the main ingredient for the letrozole is the same, isn't it, Vic? It's
Yeah,
but we know that some of the other ingredients that are added to it might actually affect people differently, so give them those side effects. So if it's possible from the dispenser that they can dispense you a different make, that might be an idea. Um, it might be a case that, maybe you're not doing as much exercise because you're scared of doing exercise. But if you're able to, and I don't know again your situation, but if you're able to mobilize and do something like stretching, like yoga, Pilates, we have some really good sort of videos for people that are on breast cancer treatment that have, we have exercise videos. There's some really good ones on YouTube and also on the NHS website as well. You might just need some physiotherapy, for instance, if it's just to get you moving or show you some exercises to do. Obviously, you want to rule out anything that's not, something that's you would want to rule out anything like the breast cancer has gone to the bones, which is really highly unlikely. But if it's a continuous pain that's not being helped by pain relief, you know, for
yeah, that
instance,
has
then
no obvious cause, isn't it, really? And
exactly.
it's
And I
sort of
think
like
that
very
is,
specific, isn't it?
yeah,
So,
it is, and it's
yeah,
sensible to do that. But again, it's much more likely to be the side effects,
absolutely.
the
Yeah,
menopausal side effects, unfortunately, that can happen. But there are other alternatives for what they call aromatase inhibitors, which are the tablets you're on. So there are a couple of other options which might be more suitable for you. And again, we get phone calls saying, "Oh, is letrozole better than Arimidex?" Well, they're all really good. They all work the same, but you know, I might be okay with letrozole, but actually you're clearly not, but likewise, I might have really bad side effects from Arimidex, and you'll be absolutely fine on it. So sometimes it's about trying it. The other thing that, might you say you don't want to come off the medication, I understand that, but it's also a quality of life balance, isn't it, Vic? So it's about asking, if you have been on it for a year or so and you've tried other things. I don't know if you've tried other aromatase inhibitors, but about asking what your sort of potential additional benefit is to taking it. Some women will say if it's only sort of 0.5% added onto the treatment I've had already, do you know what? I'm fed up with these side effects. I'm going to I think I'll stop it. But again, it's got to be a discussion between yourself and the
yeah.
treatment team. It's really
That's right.
important.
And Addie, it's really important, isn't it, that people do talk to their treatment team. I
Yeah.
mean, they can call us, of course, on the helpline
Yes.
or
Yeah.
via Ask Our
Talk it
Nurse
through.
service. Of course, we don't have clinical notes,
No.
so we can't, but it's about getting information, isn't it, so that
Yeah.
you're empowered to make a decision that's right for you. And Addie, one of the things, I don't know if you've ever done this, but sometimes when you take a medication, to score the side effects out of 10, so naught, say for Emily, a letrozole with her pain, naught is no pain, 10 is the worst pain ever, and actually score your pain on a specific
Yeah.
brand.
That's a good idea.
And,
Yeah.
because some people then, they've said, oh, I was on this brand and I was fine with it. But
Yeah.
actually, if you write it down, that sort of does help your treatment team and they can push for you to keep with a specific brand. But I know I was with an oncologist at one of our events a few months ago, and someone was really struggling with the joint pain, and he was saying you shouldn't have to put up with that.
No.
And I agree, Addie. Your quality of life is
Yeah.
just so important, isn't
Yeah.
it?
Absolutely.
And so we hear from many people that don't want to stop it. Well, let's do everything that we can by talking through your
Yeah.
options so that you can, again, it's live well, isn't it?
Yeah, absolutely, absolutely, and it's I know the fear is there, isn't it? That, oh my goodness, but if I'll berate myself if it came back, even if it was 0.5%, I want to do everything I can, and that's fine. But as
Yeah.
like you say, as long as we're doing everything we can to help you, support you with that. That's the
Absolutely. And
thing,
like you
isn't it?
say, the exercise videos that we've got are really useful, aren't they? I think
Yeah,
we
yeah,
underestimate, don't we, the power of physical activity, which can be really hard if you're
yeah,
really struggling
absolutely.
with joint pain. But
Yeah.
yeah, there are resources on our website. So again, if anyone would like information about that, you can always call us on the helpline and we'll guide you where to find it.
Yeah, there's also, of course, which I sometimes forget to say, but complementary therapies such as
Mm,
acupuncture. I mean, again, you need to, discuss with your treatment team if it's safe for you as an individual. But honestly, people have said for pain relief, it can be really useful, and there are other complementary therapies as well. But yeah,
yeah.
always contact them first. But
Yeah, but
yeah,
like you say, it's important to be listened to and heard. And
yeah,
this situation is really real for you, isn't it? So we're here for
yeah,
you, Emily.
yeah, we are. Thanks for asking the question. Good luck. I think uh, I have a question from a lady called Sheila
Hmm.
Vic, and she says, I finished my treatment last year and my first mammogram is due next month. I've been doing okay, but can't help worrying that they'll find something on the scan. I can't sleep or concentrate. Is this normal? And again, we hear this a lot, don't we?
We do. And you know what, Sheila? It's good to hear that you've been doing okay. That's that's a positive, and we like positives, don't we?
Yeah.
But Sheila, you would be amazed how many people we speak to on our help, ask our nurses, or through the helpline or other events that we go to, that actually they're doing okay through their diagnosis and treatment, but it's often when that treatment finishes that the enormity of what you've gone through sort of, I always say, bites you on the bum. It sort of hits you, doesn't it? And yeah, it's really real. And we often hear, don't we, that actually the first mammogram, the first anniversary,
Oh,
can
mhm.
be a really, really anxious time, can't it?
Yes,
Because
definitely.
often it brings back memories of when you were maybe in that unit for your diagnosis and the cancer happened before. How do I know it's not going to come back? So, Sheila, you're not alone in how you're feeling, and I'm sorry to hear that it's affecting your sleep. Um, there are ways that we can support you, and we've got some very good information on dealing with anxiety and worrying thoughts. And these include some videos, and also some written information looking at practices like mindfulness, distraction therapy, and also, Sheila, this is a really good example of something that you can actually ring the helpline and talk to one of our team and just talk through exactly what it is that's worrying you specifically. Is it the fear of it, them finding something else, and how that. And I know on the helpline with you and Addie, we've spoken before, haven't we, about how we've had people that have been really anxious about certain things, but by
Yeah,
talking it through and talking through strategies, it can really help. But Sheila, that anxiety exists and it's real for you.
yeah,
It really is. So I guess the challenge is for you to be in control of the anxiety rather than the anxiety in control of you.
yeah.
So we have got information that have got some top tips, like I've said, about practicing mindfulness, distraction, talking things through that you might find useful, and
Mhm.
also a very good video that we've done about how to manage worrying thoughts because they're real.
Yeah, yeah. Particularly, we did I did a Facebook Live with Dr. Mike Scanlon. We can perhaps
Mm,
put that link on afterwards. But yeah, about how to help with strategies to help you sleep. He also does some videos, really useful videos, and I think you can find it on YouTube on how to combat worry and concern. That's in general for anybody that's having problems sleeping or anxiety, coping with anxiety.
yeah,
And the NHS also have very good videos and some strategies, managing coping mechanisms to help with that as well.
yeah.
But
So
yeah,
there are lots of resources out there that we
yeah,
hope you find helpful. So
Yes.
Addy, we've had a question in from Michelle, and she's asking, I have a question about, do all chemotherapies stop working eventually? How long can people be on chemotherapy for? That's a really good question, Michelle.
Yeah. So does it stop working? Um,
Yeah, does it stop working eventually?
okay.
So we know
Oh yes, yes.
it does
Sorry,
stop
I've just
working, doesn't it? You know, so
yes,
you're
of
given it
course.
for a period of time, and the purpose of chemotherapy is to destroy
Yep.
rapidly growing cells, and we know that cancer cells, breast cancer cells, are rapid growing cells,
Yeah.
as are hair cells and nail cells, which is why you know it affects your hair loss. So chemotherapy, once you've administered it, it doesn't stay in the body for a long time. Once it's administered, then it will leave the body, and it's done its job then, because if there
Yeah.
are any stray cancer cells, it would kill it at that time. And the reason that you have it in cycles is so that it destroys the cells at different types of the cell cycle.
Yes. So you've answered that beautifully there. Yeah. Sorry, I couldn't see the question. That was why I
Oh,
didn't
didn't you?
answer it. So I'm
No,
so
I'm so
sorry.
sorry.
It's all right.
I'm
um,
multitasking, but not very well, Addy.
no, you're doing very well. You're doing very well. I'm the one who's missing out the questions. But yes.
Not at
So
all.
yeah, and of course there are lots of different regimes now, aren't there? It used to be sort of one or two or three sizes fits all, but actually now there are so many different regimes because treatment is tailored to the individual. It's called personalized
Absolutely.
treatment, and
Yeah.
so that, which is a good thing because it's all to help so that people aren't over treated, and it's the right treatment amount of treatment for them as an
Yeah,
individual. So
and that's a
that's
really
really
good point,
important.
Eddie, isn't it? Because sometimes people will talk on forums or something, and they might think, "Oh, well, that lady had 12 weeks, but I had
Yeah.
14 weeks, or I had 8 weeks." You
Yeah.
know, and it can be worrying, can't it? If you think, "Well, why are they different?" And like you say,
Yes.
there's a real emphasis now, isn't there, on personalised treatment
Yeah.
according to
Yeah.
the specifics, the biology of your breast cancer. So
Yeah.
Michelle, I hope that's answered your question.
Um, shall I shall I ask you another question?
Yeah, come on now.
Yeah. So, okay. So I am 6 months. So Lorraine says, I'm 6 months post-diagnosis with invasive ductal cancer and DCIS, which is ductal carcinoma in situ. I underwent 15 sessions of radiotherapy, which I reacted badly to. I have now been told that I have lymphoma. I think she means lymphedema in the
Lymphedema.
breast. Yeah, lymphedema.
Mm,
Is this common, and what's the best treatment?
mm.
Yeah. So
Oh,
it's
Lorraine, that's hard. So for
yeah,
people who
that's
are
hard.
and not so aware, the DCIS stands for ductal carcinoma in situ, and so that's a non-invasive type of breast cancer. And it sounds, Lorraine, as though you had that in addition to an invasive breast cancer. Um, I'm wondering how old you are. You had 15 sessions of
Mm.
radiotherapy, so I wonder if you may be under 50 and you reacted badly to that. And I'm sorry to hear that, Lorraine. That's hard, isn't it, to have radiotherapy reactions.
Hmm.
And like you say, lymphedema in the breast. It's not. I wouldn't say it's overly common, would you, Addie, to have lymphedema in the breast? It is a side effect, but
It's
you have a
becoming more
special
common.
interest in lymphedema, don't you? So maybe this is one
Yes.
for you, Addie.
I mean, it might not be, true lymphedema. Like you said, it might be just a reaction from the radiotherapy. It's very difficult to tell sometimes. You can get fluid buildup, and sometimes after your surgery, you might have a bit of fluid there in the breast that's called a seroma that actually, but you could still possibly have the radiotherapy. So it might be a combination of all those things. We are seeing a bit more sort of breast swelling, more than we used to. But and if it's in the breast, it's a bit more difficult. If it's 6 months after, so yeah, I mean, obviously, the obvious thing, I suppose, is having a really good fitting bra. So going for a bra fitting, because if you've got swelling, you may be a completely different size,
Mm.
and also on one side than the other, it might be slightly different. So, and comfort is really important, but wearing a bra at night time is a good idea. Um, and I think what you need to do is really to have it diagnosed. Go to your team and see if that's what it is. And sometimes, if it is lymphedema, then to be referred by your team or your GP to a lymphedema specialist practitioner is the best bet, and as soon as possible, because lymphedema is a swelling, but it can't be cured, but it can be controlled. So if it's not just a reaction to the radiotherapy, and it might be sort of they'll tell you to sort of hang on and wait and get a comfortable bra and see what happens, and before they refer you to a lymphedema specialist, or have a referral to a lymphedema specialist, and they will be able to tell you probably the best way, if it is true lymphedema or if it's post radiotherapy changes, and be able
Yeah.
to maybe suggest some massage or some exercise to do to move the lymph along. But I think a specialist, lymphedema specialist is the best, or a physiotherapist if you haven't got a lymphedema service.
Mm.
But yeah, certainly go to your treatment team and get a diagnosis first.
Yeah,
Yeah,
that's really important, isn't it? And they can assess, you specifically, because there are some things that can help, can't there?
there
Now,
are.
Addie, we were talking earlier about oh, I had about hormone therapy, and I just want to. Jude's asked a question that she's tried three forms of a tablet form of hormone therapy, couldn't tolerate it, and now on fulvestrant, which is causing her many side effects. Are there any options if I decide to stop the injections? So I think really, Jude,
Mm.
we've covered this sort of
Yeah.
in a previous question that I hope. May have helped answer you, but it's really important you to talk to your treatment team. It sounds as though you're having a bit of a tough time on your hormone therapy.
Yeah.
But again, scoring things, Jude, 1 to 10 or 0 to 10, how
Mm.
they are. And it's difficult to understand from your what side effects that you can't have. So again, do call the helpline, and we can guide you as best we can according to your situation.
Yeah, no, I think that's absolutely right. And yeah, it's just really difficult, isn't it, really difficult to say whether there are any other options for Jude. So, that it's really important that she gets that information from her team.
Absolutely, yeah, so you can
Yeah,
make a decision that's right for you. Yeah,
yeah. But do
yeah.
call us for further support. Yeah, do give us a
Absolutely,
call on
absolutely.
the helpline.
And Addie, I'm going to go ahead with another question. But we've had a question in from Sally. So
Mm-hmm.
Sally's 39 and she's just been diagnosed with ER positive, so estrogen positive stage 2 breast
Mm-hmm.
cancer. She was also told yesterday that it's HER2 positive and that she'll need chemotherapy.
Yeah.
She wondered how the HER2 affects prognosis and what it means for the cancer. Does it mean it becomes more
Yeah.
aggressive? So this is
Yeah.
a really good question,
Yeah,
isn't it?
it
Because
is.
Sally will have different treatment to somebody else, but I
Yeah.
think it emphasizes the individualized care that Sally's
Yeah.
going to get.
Yeah, absolutely. And yes, of course. And when we said talk about HER2 positive cancers, we're talking about a protein called HER2, which is overexpressed in some cancers and can be stimulated by the cancer to make it grow. I think that's kind of the best explanation, really, the simplest explanation. And the birth of sort of birth of Herceptin and those targeted therapies have been amazing in,
Absolutely, they have.
curbing that and stopping, those cells from dividing and growing. So it's been a game changer, basically. Um, Oh, I've lost the question again. But it honestly, it's really a really good question. Um, there's only about 25, is it 25% or 20% of all breast cancers are HER2 positive. So it's not that common, but the fact that you can have, Sally, you can have the Herceptin is a really good, extra treatment that you can have to try and suppress this. And again, it's not just one thing that causes a cancer to be aggressive, is it, Vic? It's a number of
Absolutely.
things. It depends on the size of the cancer, the grade of it, whether it's gone to the lymph node on the armpit, as to how what your prognosis is going to be. And nobody really can tell you fully, but what your treatment team can do, they can put all your, if you want to know that sort of an approximate sort of score, you can ask them to put all your details of all your histopathology, all your results in an algorithm, and they can come up with a percentage of how likely your cancer is to come back. Now, of course, you're not a statistic, you're a person, so it doesn't mean that that's going to be, what's going to happen for you, but it'll give you a good, sometimes it's kind of reassuring for people, or it gives them a good idea of how valuable the treatment's going to be for them, for instance, isn't it, Vic? So
Yeah,
I just think it's really
absolutely.
worthwhile doing
Yeah.
that.
And Adi, we know that there are so many different types of breast cancers, and some breast
Yeah,
cancers are sometimes alarmingly called aggressive. You hear it in the news, can't you? The
yeah,
most aggressive type. And
sensational.
yeah, exactly. And we
Mm,
know that HER2 positive breast cancers can be more aggressive than some other types. But however, what goes hand in hand with this is that the treatment that you're going to be offered.
yeah,
So, for someone who hasn't got HER2 positive breast cancer, they wouldn't have the treatment. So I always think whatever this cancer throws at your treatment team, they will throw right back at it with treatment.
yeah,
And treatment that's right for you and your situation. And like you say, the advent of Herceptin and now pertuzumab, so you've got the drug Phesgo. It's
there are many.
revolutionised the
Mm,
way that breast cancers are treated.
yeah,
So
absolutely.
I hope that does help you, um,
D-
Sally.
Yeah,
That
I hope so.
the treatment that your treatment team will plan for you is right for you, and the purpose of that treatment is exactly that, to treat your breast cancer. And I've noticed, Sally, that you're the 39, and it's hard. Having a diagnosis of breast cancer at any age is hard, but as a younger woman, you may be facing other life events that make dealing with a breast cancer at a younger age harder. So we have got services tailored specifically for younger women, Sally, that you may be interested in. They're on our website under the support section, or again, do call our helpline, ask our nurse service, or message us on Facebook, and we'll be able to direct you to those, Sally, and give you the support that you need at this difficult time.
Yeah, and I actually, Vic, you're absolutely right, and I know that obviously this is your sort of specialist area as well, which this is your baby, if you like, because you love supporting these younger women, well, all women, but you love supporting these younger women.
No, I
And I think,
do.
yeah,
Yeah.
yeah, you do. And there is a question that I think sort of follows on from Vicky, and she's saying she's 35 actually as well, so she's a young woman, and she's due to start chemotherapy in a few weeks, and it feels really overwhelming, and I feel like I'm the only one going through this at my age. But like you were saying, she's not alone, is she? Although it's
No.
more rarer for younger women to have breast cancer, she's definitely not alone, as you can concur, can't you, Vic?
Absolutely, and our Younger Women Together events, be that online or face to face. Addie, when I go to these events, I have the privilege of meeting younger women who are going through the challenges of a breast cancer diagnosis, but seeing them be with other people are younger women who understand what it's like going through. They haven't got to protect anybody from
No.
how they're feeling, and it's really powerful. And yeah, just a pleasure to be involved in these events. So Vicky and Sally, we are
Yeah,
here for you, and there is support tailored for you as younger women. So
no,
do get in touch.
they are. It's amazing. Yeah.
Yeah.
Um, so there was a question about a BRCA gene. Vic, did you
Well,
want
I
to
wonder if
answer,
we should come
or
to
did you want me to go?
Samantha, because Samantha's asking. She has a occurring rash on her
Oh,
right
yes,
breast,
yes. Okay,
and
yeah.
is that something to worry about?
Okay. Um, Samantha, that's a really, and symptoms or signs and symptoms are really important to address. Um, so most changes in the breast are nothing to worry about. They're benign in most cases, and even when you've got new changes that occur, if you've been very, breast aware and you've been checking and changing, rashes and lumps and any changes to the breast or nipple area are not usually breast cancer. That's one thing to say. But rashes can be due to all sorts of things. So depending on where the rash is, I mean, it could be something as simple as your changing your washing powder, for instance, or moisturizer, or something that you're sensitive to or slightly allergic to. Um, but if that's not the case, and if it's been going on for some time, it it's really important anyway with any changes that you go and report them to your GP. So get your GP to have a look at it. And if you, it might just be that they'll give you something to put on it for a week or so, and then they might ask you to come back for them to have a look at it again. If it hasn't gone away, or if it's got worse, or if it changes, then they might say, again, depending on what they think, they might say, we'll refer you to a breast clinic. They might refer you to a dermatologist, or they'll take a history from you anyway and ask you if you've got particularly sensitive skin, or or if the rash is, for instance, in the crease under your breasts, if you've got particularly big breasts. When the weather's hopefully getting a bit warmer now, sometimes you can get what they call is called intertrigo, but it's like a rash, or moisture even under the breast, in the breast crease. So that can also cause a rash that can be really uncomfortable, actually. So that can just be a case of keeping it dry, and drying it really thoroughly when you've had a shower, and it might go away. But certainly if you've got something that isn't going away and you're worried about it, do go to your GP. Don't sort of wait and be anxious about it. But just reassuring that most of these changes are not going to be breast cancer.
I agree. And well
Yeah.
done you, Samantha, for being breast aware, and for
Yeah.
asking that question,
Yeah,
So
absolutely.
yeah,
Yeah.
yeah.
Yeah, no,
Look,
that's good.
Caroline's asked a question, Addie, and we can answer this together, I'm sure. But so it sounds as though Caroline's had an expander inserted, she's had a
Oh, yes.
mastectomy and an expander. So she's 4 weeks post her surgery
Yeah.
and fitting of the expander, and
Yeah.
it's still really, really tender.
Yeah.
Caroline's done the right thing and had it
Mhm.
checked. There's no infection, but oh, Caroline, you're not sure how long you can cope with it, and
Oh,
that sounds really tough. And expanders can be quite uncomfortable,
yeah.
can't they? For the very,
Yeah.
I guess they do what it says. They do expand your skin, and I know certainly when I was in practice supporting people with expanders, it can be really, really tough and just feel really tight and almost engorged, can't it?
Yeah.
So
Absolutely.
you've done the right thing, Caroline, by talking to your treatment team. And if you're thinking, I can't bear it,
Yeah.
Caroline, go back to them. Absolutely
Absolutely.
go
Yeah.
back to them, because it could be that the program or the schedule they've got of, continuing to expand your span might not be right for you, and you might just need a little bit of time. But generally, Addie, it does settle down, doesn't it? I mean, it's the purpose of it is to stretch
Yeah.
the
Yeah.
area, isn't it? So
Yeah.
so it should settle down, Caroline, but do go back
It is.
to your
It.
treatment
Yeah.
too.
It is early days, isn't it? 4 weeks is very early days, and
Yeah,
it does depend on how big you're needing it to be, doesn't it, for the other
yeah,
side? But I mean, obviously, nobody wants you to be in pain. Certainly not. I mean, it's and wondering if you can cope with it. Like you said, you need to go back to them, and it may be that this isn't for you, but I think it's, and don't feel bad about doing that either. If it's not for you and you need to kind of maybe have have it removed, or have some of the saline taken out of it, and so be it. But it's not good for you to be that uncomfortable.
No, Caroline,
Yeah.
do talk to your team. And again, do
Yeah.
ring us if you need to talk it
Yeah,
through or
do.
just get some, you know, talk things through before you see your team. So,
Yeah,
yeah.
absolutely.
Addie, we've had a question in from Sarah. Sarah sounds like Superwoman. She knows that everyone reacts differently. Sarah's finishing a radiotherapy tomorrow. She said she feels like she's jet lagged, hungover, and she's working too. And Addie,
Yeah.
how hard is it when you
Oh,
have to
yeah.
work through treatment for whatever reason?
Yeah,
It's hard,
absolutely.
isn't it?
It is. And, I think, you know, we we don't know sometimes whether it's because of the radiotherapy, and there is something that happens when the cells are changing, or being sort of affected by the rays, that can make some women feel really, really tired. So it is a physical thing that happens, or whether it is just that you're near the end of your treatment possibly, and you're absolutely exhausted anyway, the emotion of it. And but actually, you're doing brilliantly. And I don't know how a lot of women do this, working too, but be
Yeah,
kind to yourself. I
yeah,
know it's easy for me to sit here and say that, but you'd say it too, wouldn't you, Vic? I mean, be kind to
absolutely.
yourself and look
Yeah,
after yourself. And if working is too much, or you need some time out, then it's time for you to look after yourself a bit at the moment now,
exactly.
because you're going through a tough time.
Yeah.
You still are. So
And we don't know your circumstances, Sarah, and
no,
some
of course
people
not.
have to work, don't they? Because
Yeah,
financially it's just
absolutely.
not possible. So I don't know whether, Sarah, that is a situation for you. But there is an organisation called Working with Cancer
Mm,
that may help you, because some people find this a little bit sometimes difficult to hear, but having a cancer diagnosis is classed as having a disability. So there may be some, rights that you have within your workplace, depending on what your job is, that you can. But again, do ring us on the helpline, and we'll
yeah.
be able to help that.
Yes,
So
and
so good
Macmillan
luck,
also
Sarah.
have
And like Addie,
yeah.
they do,
Macmillan have some
Addie.
really good information too,
They
don't
really
they? But
do. Yeah,
yeah,
and
do
Maggie's as well. Yeah.
yeah. There's a lot of stuff out there, and if you need to have adjustments made or take time out, then they have to kind of listen to you and put you first. Yeah.
Definitely.
Shall I? So Debbie asks, I'm currently having treatment for triple negative breast cancer. I've been told that triple negative is more likely to come back in the first 3 years than other types of breast cancer. Is this correct, and
Yeah.
why? Thank you. Yeah.
We were talking earlier, weren't we, about things that are, Debbie, that, sometimes you hear in the press, and
Yeah.
you use the word sensationalized, don't you? And I
Yeah.
think this is something that potentially could be sensationalized. However, we do know, and there is evidence to suggest, that people who have a triple negative breast cancer, it may be more likely to come back in the first 3 years than other types of breast cancer. So we know there's been some more evidence, hasn't there, more recently, that estrogen positive breast cancer may recur many, many years later. So
Yeah.
I guess that risk of recurrence never really goes away.
No.
But I would come back to you, Debbie, and say that the treatment that you're currently having, is the treatment that your team have tailored specifically for you to prevent that breast cancer, be it triple negative, be it or hormone positive. But that treatment, the whole purpose of it is to prevent that breast cancer from coming back. And that's what we have to believe in. And we know that many people who have a triple negative breast cancer, it doesn't come back. And
Yeah.
there are
That's
many,
right.
many people who can share
Yeah.
that. We know that there are people where the breast cancer does come back. So it would be wrong and inaccurate of me to say, oh, don't worry, Debbie, it doesn't happen. We know it does, but we have to believe, Debbie, in the treatment that you've had that's been tailored for you.
Yeah.
It's
Absolutely.
really important as you finish your treatment and you process everything that's happened, that you continue to be breast aware, and any signs or symptoms that you're not sure about. It's very difficult, isn't it, to be breast aware once you've had breast surgery or
Yeah.
treatment, because that
Yeah.
breast always feels a bit different, doesn't it, Addie?
Yeah.
But seek support, and if you're concerned about any changes in your breast or any other changes to the rest of your body that are persistent, they don't have an obvious cause, it's important that you do seek support from your treatment team. But Debbie, I really hope the rest of your treatment goes well. And if
Yeah.
there's anything you want to talk through specifically, then please do get in touch with us.
Yeah.
So, Addie, I think we're coming to the end of We've got one more question in from Karen.
Uh-huh.
She's on abemaciclib. What do you
Hmm.
think of it? New now, people finishing it with no cancer coming back. Okay, so but I
So,
think Karen, what Karen is asking is, do we
oh no, it's
know?
new. Yeah, it's new.
You,
People are
you know,
finishing it
the,
with no cancer
Absolutely,
coming
but of
back.
course it's been in
It,
trial for a long
yeah,
time, hasn't it? The
absolutely.
fact that it's been approved by NICE, it's abemaciclib's journey has been
Yeah,
um, very long, hasn't it?
it has, and it's a targeted therapy, a little bit like the ones we were talking about earlier on for HER2 positive, but it's like a slightly different drug, isn't it? But it's
Mm.
and sometimes they're using it for people that where breast cancer is primary breast cancer, so it's within the breast, but it maybe has a higher chance of the cancer returning. But yes, in the drug trials have been really successful in reducing the risk of the cancer coming back. So yeah, it's looking really good, and it's one of many drugs that are coming out. We hear of something nearly every week, don't we, Vic? That will help
Uh,
reduce the risk of it returning.
Absolutely, yeah, very much so.
Yeah.
Yeah. So yeah, and now we've got one final question in from Sarah, who's she's 2 years post-active treatment, and she's on abemaciclib as well. Um, So, sorry, the questions keep changing. And
Yeah.
she gets her bloods done every 12
Yeah.
weeks. So her CA153 markers have been rising, but thankfully are within range. Can anything else cause this apart from a recurrence or a new cancer? And we know, Addie, don't we, that CA153 can be markers for many conditions, such
Yes,
as some
exactly.
benign conditions. So,
Yeah.
Sarah, it's good to hear that your markers, although they've been rising, they are within normal range. So that's good to hear. But do talk to your treatment team about
Yeah.
your specific situation, because, of course, Sarah, we don't know your medical history or anything that may be affecting your markers. So,
Yeah.
yeah, do talk to your team about that.
Yes. Good luck.
Yeah.
Good luck with
Yeah,
that.
absolutely.
Yeah.
And I'd
Oh,
just like to say thank you to everybody for all the questions that you've put in tonight. Well, we've had lots in, so that's kept us on our
yes.
toes, hasn't it, Addie?
Yes.
So thank you all for watching. The helpline number, should you wish to call us, is 0808 800 6000, and the team will be back on the helpline tomorrow at 9 o'clock. And of course, we've got our written Ask Our Nurse service as well. Our next Facebook Live is due on International Day. I think, is it Women or
Nurses Day.
Nurses Day?
Nurses
Nurses
Day.
Day, International
Yeah.
Nurses
Yeah.
Day.
Yeah.
Thanks for that,
Yeah.
Auntie. Yeah, and that will be on the 12th of May. So we look forward to you joining us then. Do keep an eye on Facebook, because we may have more lives going on in the meantime. And if you could, we'd be so grateful if you could complete the survey. That
Yeah.
helps us know what's going well, where we can improve, and also any other topics that you'd like for us to do. So thank you for joining us. Know we're here for you. Have a lovely rest of the evening, and bye for now.
Thank you, everyone. Good night.